So we'll go on and let the speakers introduce themselves and get started. Thank you.
All right, so I will start. My name is Johnine Lohman. I'm an associate professor at the University of Kentucky. I am also the director of the Center for Telehealth Education, Research, and Outreach, and director of an interprofessional graduate certificate in telehealth. And I think one thing that you're going to hear from our panel, I hope you key into, is that it's really going to be an interprofessional dialogue here, because you will see that we're going to represent the lifespan, because I'm a pediatric speech-language pathologist is my background, and then we go through the lifespan, and we'll end with geriatrics, and I'll let Christian introduce herself in a second. And so really the way we kind of organize this, to play off of what Tim said, is 4 key points about providing services in a natural environment. We'll talk about benefits, preparing for the unexpected, addressing concerns, and kind of preparation. But what we did is we kind of, as we were dialoguing, looking at issues that we all face when it comes to natural environments and putting those together. So I think you'll see some commonalities that you can start planning for across the lifespan. And I think that's one thing that's really kind of neat about our panel here. So I'm Johnine, as I said, speech-language pathology, pediatrics, and I'll turn it over to the other end of the life spectrum with Christian.
Yes, hi, I'm Christian Furman. I'm a professor of geriatric medicine and palliative medicine at the University of Louisville in Louisville, Kentucky. I'm the medical director of our Traeger Institute Optimal Aging Clinic, and I see patients, do home visits and in the office and the nursing home and the hospital.
And I'm Mary Alvord. I'm a psychologist primarily, and run a large group practice in Maryland, right outside of DC, and have been doing telehealth for many, many years, and we'll talk about that in a minute. And I also supervise psychiatry fellows at Children's Hospital in DC, and within the last few years started a charity, a non-profitable charity. Nonprofit is non-profitable too, where we go in, we train teachers in resilience lessons so that they can train all of their students to really sort of scale up. So a lot of my efforts over the many years of doing telehealth is really with an eye to do, to scale up, because the mental health needs are so great. And I see mostly children and teens, but actually do see some along the age span, down and up.
Right. So we have our conflicts of interest here, and what we really wanted this to be was more of just kind of a panel discussion. So our PowerPoint slides are for those folks, kind of like myself, that like to leave with some printed text and that need visuals. So the PowerPoints are really kind of just there for that type of learning style. But really what you're going to hear us talking about are the issues under these 4 main types of questions, and then sharing some examples and way that we address that. So we'll talk for a little bit, and then we'll turn it over to the audience for questions, and then talk some more. So our first issue is really talking about the benefits of providing services in that natural environment. So I'm going to turn it over to Mary to lead that conversation.
So many benefits. I started actually exploring telehealth in 2005 when most people weren't using it. It was grainy. The audio was what saved us through the telephone, though, not through the telehealth system. But there was a practical aspect for us. We opened a second office location, and being right outside DC, the traffic, even though it's an urban area, it can be so bad that it could take 45 minutes, which made no sense for providers, which we started, to really come to one office or the other for staff meetings, supervision meetings, all of the administrative. So we started with telehealth back then. And the other aspect for us is that we do cognitive behavior therapy with a lot of exposures for anxiety and OCD. So our earliest work with this with patients was mostly in the home to do exposures that we could not replicate in the office, and also in parking lots, school parking lots, for example, for schools who were, kids who were school avoidant, to sit with them, do a lot of the exposures there. We have done them in malls, and so with that we have to have some privacy considerations, headphones and other things. But With the exposure therapy, we really want to do this so that it's in the environment with the goal of generalizing. Because when we are in our office, our goal is to generalize, but if we can actually do it in the real environment, that steps it up. The other aspect, we do a lot of parent-child interaction therapy, PCIT, for those of you who may be familiar with it. And what we have found is doing it in the home has been extremely beneficial. And there's John Comer has done, he's in Miami, done a lot of research on the efficacy, effectiveness of doing PCIT in the home. Because in their office, we're coaching the parents, and we're going to talk more about coaching, but we're in there with the child with headphones and trying to get them to do it. But in the environment, the parents are coping perhaps with other children that they're trying to contain, with outbursts that may happen that are not going to happen in a more controlled setting. And so in the moment, we can intervene. And that's the power of telehealth. I think not only many of the barriers of traffic and mobility, but in terms of, the intervention. And the other thing I found extremely helpful, and we don't do a lot of this, is for people with hoarders who can show you just a little part of their home so it's not so overwhelming, and so we can work on it right then and there. So the big message is, working with families in their natural environment. There are barriers that we have to overcome with that, but the gains are so much more.
Yeah, I would just echo that really, in geriatrics, like a home visit is the gold standard, like to actually see someone in their home. And it's hard, like you're driving all over, creation, seeing people. But with telehealth, you can see people in their home instantaneously without all the travel. So it really has expanded our care in geriatrics. So, and what makes the home visit so cool is that you get to see their family and the actual, what's actually happening. Because in the office, people kind of pull it together for this office visit. They dress up, they're on their best. But in the home, you get to see how it truly is, and how they're interacting with their family, and it's hard to. It's just like a picture is 1,000 words, right? So that's what telehealth is. It is a home visit, So it's really opened up our opportunities a lot. And when you're doing a home visit, you can, and we're going to talk about the culture and the permission, but you can ask them, can I look in your refrigerator? And you can see, do they actually have food? And it's like, no wonder they can't take their medicines, they can't even get food, but you don't even know that. You can figure this stuff out instantaneously on a home visit, and that's what a telehealth visit is. You can see the rugs on the floor, the tripping hazards, right? And a lot of times in their office, they don't even know what medicines they're actually taking. And if you're doing a telehealth visit, you can say, well, go to your medicine cabinet, pull out the bottle, show it to me, and you can actually see the dose of the medicine, what they're actually taking. So it really helps with the care of older adults. And one other thing that I just remember when I was doing, during COVID, is when we really started doing telehealth in our office. We're not doing it back in 2005, I must say. We've been talking about it forever, but it all happened in a day. And you're in the home, you see their artwork, you see their pictures, and so you can ask, and get to really know the patients a lot better. And so it really it really opened up a lot of doors for us.
Sure. I think doing home-based services via telehealth was very natural for me as a speech-language pathologist. I do early intervention, and I had done schools, so I consider a school environment that child's natural environment, because that's like their job during the day, So I found that a very natural transition to go into that natural environment there. But I would echo what the ladies say, but just to kind of give you an example of by being in that child's environment, I was working with a young child, 5 years old, cerebral palsy, and she had no means of communication. So we're a 5-year-old, and we are just kind of screaming and grunting. And I'm like, oh no, somebody's dropped the ball here. We can get this taken care of. So what was so nice about being in her environment versus her coming to our clinic is in one session, we were able to go out, and she loved swinging. So we were able to take the iPad outside and set it up and get a communication device that the mother could use, because we were working on requesting swinging, and figure out how the mom could handle that communication device outside while engaging with the child swinging. And they just set the iPad up on the outdoor patio furniture so I could watch, and coach. And then from there, because she would move between activities quick, her attention span was limited, we went back into the house, and they were having some meal and food issues, because it was like you'd go to the refrigerator and she would just stand there and cry. So I was able to see how that exchange happened, and we were able to have a communication device that we could have there on the refrigerator door and work with mom of how we would use that, and then start pairing items. And as Christian said, I could see what items were in the refrigerator, so we could tailor that. And so I would make the communication boards, and literally I would mail them, and we'll talk about that more, mail them to it, and then they would have it there, and I would show mom where to put it. And then after we were outside for a little bit, we were at the refrigerator for a little bit for a snack, then we went, and she loved looking out of the front door and looking at the cars. So we could talk about how we could take that activity of looking outside and make that into a communication exchange. And so we got to see these varied routines while following the child's lead, which is a recommended practice in our therapies, is kind of following that child and communicating about the things of their interest, and then be able to show mom how to do that. And I could never have done that in my office, nor would I have had her preferred interest, which is going to make her want to communicate more, because we're talking about the things she's interested in, not just the things that are in my little 10 by 10 square for that. So that's just a real benefit, I think, of environment.
Right, just to add couple more things. So often we'll work with children and teens, and there may be other adults that are part of their life that we can easily bring into the screen. So we may have a nanny or a grandparent that's doing a lot of childcare, and we can have them come in for 10 or 15 minutes to really collaborate and do planning, whereas it would not be practical to have them just come for 10 minutes to an office, drive 45 minutes for 10 minutes of time. I had to pivot very quickly. I run a lot of groups, and the shutdown was the 16th. Schools ended March 16th, and on the 14th, which is a Saturday, I was running groups. So we had to quickly figure out how to do this in the natural environment, in virtual. And I think what we have learned so much is that we can use this to our advantage. So one activity that kids really loved, which is the advantage of being in the home, is I would say everyone find something in your home. I don't say house, because a lot of people live in apartments or maybe in alternative housing. So in your home, where you are, that makes you proud. We'll do another, and then they have to describe it. So a lot of relaxation, right, in terms of this, engaging all the senses. What is the color? What's the shape? What's the texture? And the other kids have to guess what it might be that they're proud of. Is there a question?
Hey, I'm homeless, and I'm trying to get me somewhere to stay. Can y'all help me?
Right now, here?
Yes, yes, ma'am.
We can try to talk to some people and see if we can help.
Because I'm homeless. I don't want nowhere to stay.
Okay, right?
I heard you said something about housing. That's why I raised my hand. I'm homeless. I don't have nowhere to stay.
Okay. We'll try to hook you up to somebody
Okay.
with services here.
Okay.
But that's what we try to reach, because we don't assume people have a house or, where, and so we meet them where they are.
I've been homeless for the last 4 years. For real.
So I think that,
I ain't got leave, man.
what we really want to do is engage the kids. And so we talk about find something in your room or where you are in your space, and maybe outdoors, that calms you. And so these are ways to really engage, and telehealth is just a savior. But again, we're looking at what's in the home, What are they doing, and working with whatever materials that we have.
I will add to that. I think I'm going to jump in here. I think one thing is, as we move into this idea of working in the home, I do think it takes a mental mind shift as the provider. I feel like it's very easy when you're in the clinic, you get into your routine, and the focus can be more on, procedural. I'm going to do this, I'm going to do this, and I'm going to do this. And kind of just because you get rote, you know how you drive and you go, how did I get there? Do not tell me y'all haven't done that. You get to work and you're like, oh, I don't remember. Okay, so that can kind of happen. I notice that can happen to me. And so sometimes I lose sight of, why am I doing this procedure or this technique or this intervention or this assessment, and what information do I get? And so I feel like when you start doing telehealth in that natural environment and looking at using the materials the family has, the routines, like what is their mealtime routine? It is not my job to interrupt and tell you your mealtime routine is wrong. My job is to figure out how I can help you with communication and swallowing and feeding within your routine and make it safe, So I feel like when you start moving into doing therapy, doing the telehealth in this natural environment, you have to really start asking yourself, what information do I need and get out of this clinical encounter, whether it's a diagnostics or a treatment or a consultation, and what am I going to do with that? So why do I need it, and what information do I have? Then I can start thinking about, well, how am I going to get that information? And I think about, well, how do I do it in person? And then my mind says, how do I do it via tele? And so I have found that if I just think about the how do I do it, then it can become a barrier, and I can say, oh, I can't do that in tele. I need to touch them, or I need to do this. Versus if I back up and if I say, what information do I need and why do I need it? Now what are alternative ways for me to get to that? Or what type of treatment do I need? So I really would encourage you, as you're thinking about this, particularly if you're newer to doing things more in the home and using the materials that they have or tools that they have, or using a mirror. We use a mirror a lot to see things, and thinking about alternatively. Like if I need to see you walk, I work with PTs and OTs. Well, put a mirror behind you so I can look at your gait. I don't need you to come in. I can figure that out. So that's where I just am trying to emphasize, really, I think it's this shift of, what information do I need? Why do I need it? Is it really that critical, or is it just something that I'm so rote to doing? Then start thinking about, how can I modify and get it a different way? And does it have to be done the way I would in the clinic? The last thing I want to say, and then I'll stop on this slide, is with the coaching. We do a lot of coaching with families, because really my job is to empower that family, is how I see that. If I can teach you how to facilitate communication for your child, or do safe feeding and swallowing, then you're going to be empowered, and you're going to be able to problem solve, and you're going to be a more confident mama, daddy, care provider, whoever you are, grandparent. And so I will say that when it comes to the coaching piece, we have to start with that conversation of having them kind of take over and become the coach, and then actually spend time and have time carved out to teach them how to coach. I just can't throw it into it. So I do have sessions where we're teaching the parent the skill and having them model it, and they're watching me model it. So as you're thinking about coaching, if that is something that's appropriate for your healthcare profession, then you need to plan within your therapy treatment plan time to actually coach and teach that family caregiver.
Should we go to the next one? Or no?
Just one more thing. And I think working with children and teens, you need to also think about what materials do they need at home if you're doing telehealth. So there may be some games that you can actually play over. I don't like to have them sign into games to do with us if we're working on engagement, because I don't want them to release email information. So we have a lot of things, but also, how do you prepare the environment so it is conducive? And I guess, just as a disclaimer, I love telehealth. I've been advocating it for years and years, but we also have to differentiate when it works, and we also have to think about when it may not work for certain populations, as well as would a hybrid approach be the best. And so with setting up the environment and then using the environment when you need is gold.
All right,
Yep.
so, good. Okay, we're going to talk about our next.
Questions?
We have a question?
Yeah.
If we can go to questions for about 10 minutes. Carlos, first, I'll see if you have any Q&A in your,
Not at this time, Tim.
all righty. Any questions in the room?
'Cause we can-
We get
So can I
maybe
ask a
lot of
question now?
information.
How
Sure.
many of you work with children and teens? I get an idea. Okay, but, and rest adults? And would you say you've been using telehealth for maybe just since the pandemic? Okay, a few, and many of you for a long time. Okay, great.
Do you want to just go on and get started
Yeah,
with the
well,
rest? Okay. Okay,
Yeah.
good.
Go ahead.
Yeah.
Hopefully you can hear me. So my question is this: if you are, I'm a child adolescent psychologist, and if we're doing a treatment that involves another caregiver, and if the adult, I understand that I as the provider need to be licensed in the state where I am, and I also have to hold a license in the state where the client is located. But if a grandparent, let's say, is participating in a session from yet a third state, but the grandparent is not my client, they are simply, collateral member of that particular session, not ongoing treatment, but just coming in for that session. Is there an obligation for me to also have a license in the state with the grandparent? I don't believe that's the case. I just want to make sure.
You want to just repeat the question?
So the question is, if you're seeing a client in another state and you're licensed in both, or I would say for psychologists, we also now have Psych Pact, so that we are allowed in 33 states, if you're licensed in your home state, to see somebody in one of those other Psych Pact states. And the question is, if a grandparent joins from yet another state, are you obligated to be licensed? I would say, no, they're not your client, but you do need to know, I think there's an ethical aspect of it. You need to know what resources are there, because there might be an emergency or some kind of something that you have to deal with. What is the support system there to help you?
Question?
But I'm not a lawyer, but that's my
Disclaimer.
understanding from being involved with Psych Pact too. And I don't know if that, from
Yeah.
another profession, how does
That's
that?
always been my understanding
Yeah.
and how we would treat it. Yeah. All right, go to our next.
Oh, there's another question?
So I used to do a lot of home visits. In fact, I still do some home visits, so this was sort of pretty normal for me, but I wonder how you help other providers who maybe feel like the home environments are so out of their control that they're not comfortable. What are the things that maybe you say to them to help them feel more comfortable with that lack of control?
And you're talking about other providers that are doing this and how to kind of help them through. I think maybe that's partly the preparing for the unexpected. Do you think we should go through the next part of our presentation, maybe? Because I think that's because this uncontrolled environment is the unexpected. So I want to go ahead and go to the next slide, I think, because I think,
Yeah.
did I do it right?
It takes a moment.
Oh, there you
All right.
And we have, is that part of it?
Yeah.
Okay.
All right, you're good. So we're going to talk now about kind of preparing for the unexpected. So I think I can touch on some of what you have, and we all will, and I think this might help some of that, because I think that's where some of that fear is the unexpected. So one of my first home sessions, my very first session was more controlled with a little boy, and that was more of that facility to facility when we were first dipping our toes into it and everything, and then we moved very quickly into home. So my first experience on tele in a home is the top picture. And that's how she sat, And this was back in 2014. So just even getting the family to even do tele was a stretch, for that, but they wanted the additional services that tele could provide to them. And so I learned very quickly, and I mean, I'm a seasoned therapist, and I thought, I kind of got this, but obviously I didn't, because that's how she said a lot of the times, because we said something she didn't like, and she has a little stubborn streak in her, and so that's just kind of how she was going to be. So I guess the first thing I would tell you to do is think and brainstorm a list of unexpected things that have happened in your in-person, and how did you do that? And then expect that they're going to happen on tele, right? Because it's the same thing. And then I would say take those things that have happened, then go, okay, what are the craziest things that might happen? Like almost the never would happen. I mean, like never. So I'll give you an example of one, and this didn't happen to me, thank the Lord, but I've learned, and we have new policies now. Is one of my peers, she was seeing a young man in a school setting, and he dropped the camera and exposed himself. And we didn't have any policy for that, of how to handle exposures like that. And so we had to go back and start thinking about our policy and our procedures for that. So then that really got us thinking about, what would you never expect to happen? Like, let's get crazy. And then kind of starting to think through, what are some things you could do? So for your peers where there feels like there is no control, I think if you know, what do you do if, another case, we just had this a couple weeks ago, the patient started saying and talking about killing themselves. It was an adolescent. And so what is going to be the protocol to keep them online, to get mom, to get that going? And I'm a speech language pathologist, so God love you, psych people, you would probably know instantaneously, and we're doing the best we can, So I think that would be one thing I would say is go ahead and pre-brainstorm, so you kind of have a set of plans for that. I also would say, kind of staying with your point, for your friends that are feeling uncomfortable, I think having them go back and think, like I said on the other slide, why are you doing this? What do you need? What is the end game? Now let's think about how you would do it in this maybe chaotic environment. So with that said, I would say some things about planning is, one, really thinking about your client's technology literacy and your technology literacy. Our patients use a variety of different devices, so I have to be skilled on being able to troubleshoot on a PC, on a Mac, on a no-brand tablet, on an iPhone, So I, as the provider, need to feel confident in that, because if I don't present as confident, then my family start getting anxious. So I would say, being confident so you can start walking through that. We, as part of our intake, we ask them which devices they have access to. Now, that's a little different than for those of you that might be physician providers, because in rehab, I'm seeing you every week, if not a couple times a week. So this is an ongoing type relationship. We will not see children on a cellular phone. Like we just cannot do services on a cell phone. We'll do a consultation, we'll do some coaching, but I cannot do feeding therapy on a cell phone and make sure you're doing a safe swallow. So we have some of those rules up front, so we know the devices. The other thing we've done that really helps us is we've developed a set of tip sheets with basic troubleshooting lists there. So when you start having a freak out moment, I can go to my list, no audio, video, here's what I do. And then we've developed tip sheets for each device. So we have one for an iPad, for an iPhone, for a Mac, and it's like, if there's no audio, here's how you might fix that on a Mac. Here's how you might fix it on a PC. And so that helps alleviate some of the stress for that. The other thing is, in predicting, is we try to be aware of what software might be on that device for that family. So if they don't have productivity applications like Office, then, if I send them documents that are going to be in a PDF or something that I need them to sign, they may not be able to do that. So thinking about how they could sign them digitally. So thinking about some of those pieces of software that they would have access to. The other thing, as I'm thinking about technology literacy, particularly on my side, is, do I know how to use accessibility features and how to walk my client through? So if they need the font size larger, or they need to change the screen color because we have some color blindness or visuospatial problems or some hearing problems, and we could boost the speakers up for them or make it a mono speaker, or even doing some shifting if we have some CVI, cortical visual impairment, and doing some shifting. Do I know how to use those features to help my patient walk through those and to guide them? So I would, talk about that. The next thing I'm going to say quickly, and I'll turn it over to my friends here, is privacy, safety, and security is really thinking about and working with your families. Are they where will be a safe place, where will be a private place, where the neighborhood kids are not walking through, and making sure that they know this is like an office visit. And also then communicating expectations. So I'll say this and then turn it over. I think to help alleviate some of that chaos, if you communicate with your family, in my case, what are the expectations? Because this is still a billable clinical encounter. And I'm still billing, and there's still ethics here. It's not a free-for-all. So, we talk ahead of time. I expect you to be dedicated this 1 hour session. So TV is off, cell phones are put away. We talk about lighting. We talk about where the placement of the tech is going to be. I talk about, Mama, I can't have you cooking dinner if I have like a 5-year-old, I need you to be present. So for example, we had at the end of a session once, I told the little one, I said, okay, go get Mama because I need to wrap up, and he could handle the tech and everything. And Mom wasn't in the house. And I was like, where? Well, she had stepped next door to the neighbors. And so I thought we had had this conversation, and we had, but sometimes you have to come back and have the conversations again, about that. So really kind of laying the ground rules ahead of time as to this is what I expect and what you can expect from me even. You can expect me to be in a private environment if I'm working from home. You can expect that my child isn't going to walk in the background, and so we set those up front. Did y'all want to comment on these?
I just want to, again, reinforce many of us here have been doing telehealth for a while and are actually training other people who are newer to it. And there is, I think, a fear of I'm not going to be able to control as much. And even all what Janine said, we need to, anticipate, because now we all have experience of all the possible emergencies, crises, difficulties that may come up, but there are always new ones. And I think that's where sort of peer consultation, making sure that there are others. So if you're training others to start doing this and they're hesitant because they feel like they can't control it all, is to say, yes, but let's have this little peer group, even if it's just 2 people, for support so that we can problem solve. And I think knowing that gives the clinician more confidence in stepping into something new. We had a new situation. We were doing a scavenger hunt, and a little girl stepped on a fishing hook that was in her room when she was running around her room. And we always say parents need to be home. We have their phone numbers, we have their emails, but they need to be accessible. Well, the whole family was outside because the Blue Angels were flying by that day. And they couldn't hear the phone, they were ignoring everything. And here's this girl screaming and crying. And so she contacted several of us, I wasn't running the group, and said, can you please help me? Because I have to control the other 5 kids in the group and get it, and get someone on her. So we sort of formed a little team approach to contact the parent and kept trying. And one of us was actually heading toward the home so that we'd get it. And then finally the parents heard the message and went upstairs because they were in the backyard. So that's something we would not have anticipated. But I think knowing you have some kind of a support system helps. So.
And what we see sometimes in geriatrics, and we see it in the clinic, but then it happens even sometimes more on telehealth because you have more family around. So we have a lot of patients with dementia, and a lot of the adult children or the caregivers really don't know how to interact with someone with dementia, and you see them just berating the older adult with dementia, like, I told you that, and don't you remember? And it's like, know they have dementia, they can't remember, But you'll see this in the environment a lot, because it's like doing a home visit. So you see more of the family members in this environment, and you can actually, and that's kind of goes back to the coaching a little bit, and how to address it. So you're still addressing it the same way, but it's nice with telehealth is because you can separate people a little bit more, because in the office they're all in this one room, sometimes, but in telehealth, at least if they have a laptop, you can move to a different room and get away from the person with dementia, because sometimes you don't need to have this conversation in front of the patient. So just being creative and being willing, and that, like you said, knowing that you're going to have a plan, what to do when these things happen. And I tell you, for older adults, like just the technology literacy issue, at the beginning, people are like, oh, older adults can't do telehealth. They can do it just fine, actually, and because some 50-year-olds can't do it either. It doesn't matter your age, it's just if you can be taught how to do it. And so at the beginning, a lot of times they did have their older adult children with them that were helping them get set up. But as the pandemic went on, they were doing it by themselves, and they did fine. So I think don't think that older adults cannot be part of this whole telehealth process, because they can. And the same thing, they don't want to have to drive so far, and so it makes a big difference. Yeah.
I did just want to kind of wrap up with a couple more things on our slide that we have here. When we're talking about caregivers, I do think it's important to start planning for the unexpected and the new role they have to assume. So for some of our caregivers, when we've been speaking to them, they are getting really frustrated because now they're having to assume new roles that they didn't have previously, or we're taking away some luxuries from them. So what I mean by that is some of our families that have children with autism spectrum disorder, bringing their child to in-person services was the 1 hour a week that they got to have a cup of coffee in silence. But now that they're doing it via tele, they've lost that hour. So we really need to start thinking about these unintended potential burdens that we are creating, and how can we replace those or work with the family for that. We also have to consider, as roles change, because now that parents doing the technology and becoming maybe an extension of me, my hands, eyes, and ears, how do they feel about taking on, kind of like almost an assistant role? And I've had some families who've kind of pushed back, because that changes the dynamic now. Because now it's the parent and the child, and we all know, or at least I hope your kid was like my kids, they act better for everybody else than for you, type thing. And so sometimes we have to work through that, the child not wanting to respond to the parent because of that parent-child dynamic, and making sure that we're keeping the focus of me as the therapist is the one who's giving the directions and taking some of that burden off of the family, so that that person can stay as the caregiver. So I just think we need to be thinking about and planning for maybe some of this unexpected burden that we're creating for that family. The other thing I want to say, and then I'll have my peers kind of, if they turn it over, is always thinking about your location. I know we've talked about that, but I start every visit verifying their physical address and their phone number, or our intake staff does that. That way, if an emergency happens, I know I have correct information. And the other thing is, it allows me to verify that they're in the state that I'm licensed in. We've had many families that'll go on vacation and they don't tell us that. They just think we can do tele. Or I'll have families where it's a divorced family and I didn't realize that they're with dad this week and dad's in another state. Or they're with dad for the summer, the other parent. And so I'm not licensed in that state. So we verify at the beginning of every session. It's part of our routine. And then the last thing I'll kind of talk about is, this may be a rehab thing, but in rehab, sometimes we just need specialty equipment, particularly my PTs and OTs. And you just cannot replace it with something in the house, no matter how much we try. Some of our testing requires specific forms that the responses, like my OTs have specific forms where they have to take the handwriting sample because it has to be done in a certain box size. So if that's the case, you really have to think and plan for how are we going to get equipment to that family, and then how are we're going to collect it back. So are we going to need to send a box or an envelope with a prepaid return label on it? Is somebody going to deliver it? How long is that going to take? And what's going to happen if I never get it back? I always have to think about that. So I will say in some of those occasions you need to have in your workflow what might be materials we have to get out to the family, and also put that in your financial plan. paying for that mailing and for purchasing maybe 100 sets of XYZ because you're going to mail it out to your families. Anything else?
I think we have two other pictures there because I encounter this. The first is I'm speaking to a child or in telehealth or a teen, and suddenly their face turns green or blue or keeps switching, and because they have other tabs and they may be playing games at the same time. So this is a challenge, but I'm originally a New Yorker, so I'm very direct, and I just say, your face just turned a different color, tell me what you're doing. And then we launch into it. It's a challenge. The other sometime is that there are people in the room and they don't necessarily tell us. So those are some of them. And sometimes we can ask, I always ask not only location, but are you alone? Are you in a private space, so that we can determine who else might be there or within hearing or visual range. And the other is attire. I say to all of them, please dress as if you're coming to my office. And I expect you to be sitting, I mean, basics, but with kids, you just never know. And sometimes I haven't had the exposure experience, but I have had them where they're just in bed, and they're in their pajamas, or they're just I should say, clothing that they wouldn't come to our office with. And so, it's important when you go into the home to take all these things into consideration, because it's a mindset for them too. They're at home, they're comfortable at home, but it's a professional relationship. So just wanted to add that.
Yeah, that's good. All right, so I think we're going to go to the next slide here.
So what do
Go ahead.
you do when your teen is in their like pajamas? Like, would you continue?
No, I usually say, please get dressed, find a place where you're sitting at your desk or a couch or in a private space, and I'll call you back, or, join in a few minutes when you're ready. And I just stay online. And then sometimes I've had to call a parent or a caregiver to say, could you please monitor what's going on in the room and find another space?
So I think we're going to go ahead and go, and then we'll do some more questions at the end. Is that okay, Tim, you think? So now we're going to talk about respecting private space and culture. And I love this slide. I think, Johnny, you found it, but be our guest. So, just remember, you are a guest in their home. And so you don't, even if you're in person doing a home visit, you don't just go wandering around their house without asking, right? But sometimes you really do want to see what's in the kitchen, what's in the bathroom, like, especially in geriatrics, do they have handrails in the bathroom? Do they have the rugs? And do they have enough food to eat, right? So, but you have to ask first, ask permission, ask permission. Sometimes you do want to see the family. Sometimes you don't. For me, I really need a collateral history, especially with the person with dementia. I just want to trust but verify, So you say, is there as somebody else here, is your spouse here, can I talk to them? But you have to ask. You can't just, we wouldn't run around the house without asking. So on telehealth, you can't just and do anything without asking. And the big thing about culture, a lot of telehealth is the same as in person, but we have people from all different walks of life, all different cultures, all different languages. And actually at the University of Louisville, I was just on a call, and it sounds like from our EPIC, the electronic medical record, we're able to integrate our translation services with EPIC. And so it's nice that you can actually have translators, the patient, the provider, the translator, all on the same, Zoom meeting. So you can actually, it helps a lot sometimes with translation. Being on telehealth will help with the translation. And, just being, like I said, all different kinds of walks of life, all kinds of different environments. I've had patients that really don't want me to do telehealth because I really am in their home, and people don't want people in their home, and they're embarrassed that, maybe just the living conditions, maybe they are hoarders, and they don't want you to really see the true story, So you have to really kind of walk through that. You're not judging them. You just want the information. You want to try to help. but sometimes they just don't want to give it to you. And even with older adults, they kind of can put their makeup on, get their hair done, get dressed up, and come to the office. And so when you're doing telehealth, it happens even with older adults, like they don't have their makeup on, they don't have their hair done, so they don't want to have the visit. I'm like, no, it's fine. I mean, I can still talk to you, and we can still do the telehealth visit, but they want to be perfect, So it's just talking through a lot of these, cultural issues and how they perceive the visit. And then the other thing with just having other people in the home, and especially, I do a lot of end-of-life care and palliative care, and sometimes you want to talk, you definitely need to see the patient, but a lot of it, the visit is the family, that's the caregiver taking care of this person, and they don't want to talk in front of the patient. And so in telehealth, we are able to go to a different room and then have a conversation with the caregiver. The caregiver will tell you the whole story and that they don't want to say in front of the patient. So that really helps, from our standpoint with telehealth. So I don't know if you all want to talk about the...
Well, I was just saying, I was just thinking about some of our families, what's made telehealth so incredibly practical for them and convenient is that we can engage whoever the caregivers, whether there's two parents, and they can be in different locations. We have a lot of divorced families. So then we're telehealthing into an office perhaps, or into a home, sometimes across state lines, but we're PsychPack approved, so we can do that now. And it's the richness, I think, of being able to do that. And sometimes, again, we may have a care popper pop in for a few sessions, because with cognitive behavior therapy, we meet with the children individually, often, depending on the age and definitely the adolescent, but we also like to have some collateral time or family time to go over what the plan is, the homework time. And the beauty is that we can Zoom, the parents who are far away or not, the child may not even be with them that week, can still be involved. And that, the culture comes in because we have to understand the family dynamics. How do they feel about mental health? How do they feel about these sessions? And sometimes the non-engagement gives you information of like one parent just not ever participating, and so we try to draw them in. So the culture is important. I grew up speaking several languages at home, so I'm very sensitive to multiple languages, including ASL, foreign languages, or whatever we need to help bring people as part of our sessions.
I would say, as far as watching your reactions, particularly for those of you that might supervise students, so I do a lot of student training, and we train in telehealth, and so you might be okay with different environments and the cleanliness of a house or the organization of a house or whatever, but I think this is a real opportunity to start training our students in that. So even having a conversation ahead of time, if you are supervising students, about watching nonverbals, because I've had students get on and their whole face has just told you what they thought about the situation. So I just wanted to give you a heads up about that you might be like, okay, I've got myself in check. But really when we're working with our students, thinking about that and giving them some heads up. What I did want to say about culture, kind of thinking about that in telehealth is, I would say telehealth, when we think about different cultures, and I think about culture very diverse. So I think about geography. So Kentucky we have very rural and very urban areas within Kentucky. And so I can be in the state, but culture is very different in my eastern area, in my coal mines towns versus where I'm at in Lexington. So I think when we think about culture, we need to think about it very broadly, even in terms of what term might be used. I'm from the South, and we call everything Coke. But when I lived in Pennsylvania, they looked at me and they're like, no, we have Pepsi. And I'm like, well, no, Coke is like the generic name. Those of you that are from the true South, you'll understand. Everything is Coke, right? Thank you, girl. You have me, okay? Somebody's feeling me. And so, even being aware of, do you call it a purse or a pocketbook? And so I do language, and so that's important to us for that. So I think as you're thinking about doing it, you have to think about culture very globally and include within that your social determinants of health. and how access to education and to food and to community and safety play within this. And then the last thing I will just say, because culture is culture, and I take everything I know about working with different cultures, and now what I've got to think about it, the layer that's new, is then how is that transmitted digitally? So how do my nonverbals come across that might be okay in person, but now if you're only seeing from here up, you may not see the hand gestures that I need for that culture. So then I need to back up more so you get a more full body view, right? So being aware particularly of those nonverbals that are missing and layer on top of that. And then also to the points they made, being aware of who all is going to be on the call, and are you speaking to the appropriate people to make decisions in that culture within that. So just kind of thinking about those family dynamics even as to who would make those decisions. And then our last, you want to go to our very last one, and then we'll do some Q&A? All right, so the last consideration.
Okay, so informed consent. So pre-pandemic, we had always built in, because we'd been doing maybe 10% of our practice was telehealth pre-pandemic. We had part of our informed consent patient agreement, a paragraph about telehealth, because often it wasn't scheduled, but it was sudden. We'd have somebody stuck on the beltway, they'd have to pull over, and we would talk to them in their car, but they were alone in their car. So for those emergency, unexpected telehealth sessions, we built it into the agreement. For those that we then regularly switch to, we have and still have an informed consent strictly for telehealth, all the risks. But in addition to all the normal, what are the benefits, what are the risks, is an area, a page where they have to put in all their emergency numbers, emergency contacts to give us consent should we need to get hold of someone. It's built in. So we have it immediately there, because I think from risk management, just good clinical care, we need to know, like I said, we've had a couple of instances where we have someone who has made some not just suicidal ideation, but actually talked about a plan, and we had to move on it. We had to make sure the support system was there. We had to make sure what were going to be the next steps. So we had to have on hand phone numbers, emails. We ask for, if it's minors, their parent, but who are the caregivers, who are the neighbors that they may trust, should the family need more support. So informed consent is really critical, not just for sort of the legal part, but for the practical aspects of providing good care. And as I said before, there are situations that come up that are unforeseen. So if we know we have a support system for people who haven't done as much, or just so for all of us to bounce off of each other and know, came up with this situation, what would I do, what should I do? We get calls after the session from a clinician say, this is what happened and how should I handle it? And then we document and sometimes follow up with calls. But if we have all that information at hand, then that's helpful. So now that we're going, people, especially during the pandemic, but even now, people are suddenly in other locations, and we do ask. Sometimes I have to make the call of, do I continue this session because they're in a state and I'm not sure if it's PAC approved or not? So I say, well, let's shorten the session, and then that way we can continue. But I also don't feel comfortable just cutting off and saying, oh, you're in some other state, so I can't meet with you, because maybe I can, maybe I can't, because of all the temporary licensing issues. It's gotten very complex. Now, clinically, I make a decision typically to have the session and then again have the conversation about interjurisdictional. We've gotten people angry with us that why can't we see them when they're vacationing or at their grandparents' home or something else. And so it's an educational process, because honestly, who reads informed consent, right? So you have to go kind of through the highlight, and then you have to keep reinforcing those topics. So we also have to talk about if there's an emergency, what might we do? And we talk through, especially more teens who maybe are at risk. We have to decide, if there's an emergency, and then also if we're doing telehealth, perhaps that's not the most appropriate. We need to bring them into the office to do a fuller assessment. And so again, it's how do we manage all of the the informed consent, but the knowledge, and then just managing the clinical aspect.
And from our standpoint, like the emergencies, I mean, it's the same in the office. Like sometimes we have someone, really, really, really sick in the office that needs to go to the hospital. And so when you're on telehealth, same thing. Sometimes we've had to call like the ambulance to go to the home, to take them to the hospital because, you've been telling them on the phone, they call in, yes, you need to go, and they just won't do it, right? So sometimes you calling the ambulance themselves actually makes things happen if they're agreeable. I mean, you can't do it without their consent, but sometimes in the office you have an easier chance of like pushing them to the emergency room if that's where they really need to go, and so it's a little bit harder on telehealth because they can just like, bye, I'm gone, and like just leave the so you do have to kind of think that through and talk it through, but we have called ambulances to go to people's houses. So yeah, what about?
Yeah, I think the last thing I'll kind of say, and then we could do any questions we have. One thing I would say about the consent is if you're working in a facility where they might have like a blanket consent, please check and make sure that that consent will cover all of your practicing professionals. Like, for example, at Kentucky, they wrote a consent for us, and when I looked at it, I said, this will violate my Licensure Act as an SLP, because our Licensure Act in Kentucky has 7 very specific things that must be in our consent form. It is outlined, and it must be worded this way. So I would say if you're in a team type approach and want a blanket consent form, I would really make sure it's going to cover all the licensing boards of everybody that's covered for. So that's one thing I would say. If you're going to do it across state lines and you want a blanket consent, I would make sure it reflects all of those licensing boards, or make sure you have consents for those different professions and how that will work. The other thing I will say is to piggyback on what they have, I'm a big table girl. I like table and lists, so I like procedures. For some of our patient populations, we have a treatment plan and we have a safety plan. So we've already thought through and talked about with the family. So like if I'm doing a lot of feeding and swallowing therapy, or we have a child with complex health issues, our plan is written out, safety, and here's what's going to happen, and treatment. So that's all together in our logs for that. And then the very last thing I'll say about your state lines is, again, just making sure you understand their licensure laws of how you can start a new patient-provider relationship, how you might be able to continue that. Will that state allow you to use all different modes of telehealth, like store and forward, asynchronous, or does it have to be real-time audio, video? Just knowing some of those, and then also knowing some of the states in rehab will require that you document training the family on using the technology. And I have to have documentation of that. So just again, knowing what your different professions, their licensure boards require for that. Right, so I think we have 2 minutes.
We have about 2 minutes. Thank you, panel. Remember, if we don't get all your questions in, please contact those here who are in person. You can come up afterwards, or if you're virtual, you can contact the presenters through the attendee tab in the web version. Is there any questions in the room? There we go.
So we've had a couple of unique situations where, in the state of Maryland, for psychologists, for social workers, we have to inform the patient that we have to know the emergency services information and inform the patient that that's what we would call it. We feel that there's a danger. So we've had some situations grounded in reality where parents, and I work with children with behavior problems, where parents have said.
We have to wrap it up. Oh.
All right, thanks. just had situations where parents have said, you calling emergency services to my house is not going to help anything, right? And have refused and said, this isn't something we will do. So in those situations, we've said, okay, we'll document this, right? But then where's that trusted person? Where's somebody that we can reach out to in case? And then I think the other situation that's come up a couple of times are for people who are in a state protection, like a confidential address situation where they can't tell us where they're living. And so those have really been some challenging things that I think, 3 years ago, Anna and I could have never dreamt up in our, well, the first one certainly, for sure. But the second one was really new to us.
I guess you always have their IP address,
Oh, right.
right? So I'm not enough of a techie to know, but IP addresses will get you the location. Now, how you get that information, I don't know, but there is a way to track.
Yeah,
We
that's-
can document, do the best that we can, and there are these new situations, and with any risk situation, we consult, right? Talk to people, put our heads together. First of all, we need the support, and then we need to help figure out what to do with the situations. That's why I say, when I work with, especially kids and teens in the home, we've had a teen that just slammed the laptop shut, and I was like, okay, goodbye, really angry, but he was angry at a family member, so we had to contact the family member, and then we had to get them back online to kind of just diffuse the situation. But that's where some people are hesitant to do telehealth in the home because you don't have as much control. So if we think of these situations and we know what is the support system, who are other people that can be called upon, who are geographically close, proximity helps, and then do the best that we can.
Thank you for your time. We appreciate you coming to this session and giving us your attention. Thank you so much.
Thank you, everyone.